So hello and welcome to this inaugural joint education webinar of the International Society of Renal Nutrition and Metabolism and Kidney Disease Improving Global Outcome. Today we have an interesting talk on lifestyle and some discussion, and I would like to hand over for the first slide to Angela Wang. She is the president of ISRNM and she wants to give you one introductory slide. Please, Angela.
Thank you, Christoph. It's been a great pleasure to arrange this joint webinar between ISRNM and also KDIGO. In particular, the guideline was the diabetes guideline was released in 2020 and also recently have done some updates with public review currently. I will leave the introduction to our moderator, who is Christoph Wanner, current president of the European Renal Association and also the workgroup member of KDIGO Diabetes Guideline. And at the same time, he's also previous past president of the International Society of Renal Nutrition and Metabolism. Now, before I start my talk, before I hand it to Christoph, I just want to show you or promote this Congress of the International Society of Renal Nutrition and Metabolism 2022 that will be in June 16 to 18. It is going to be a hybrid Congress. We are currently calling for abstract submission and also early bird registration. And I just want to mention that there will be joint ISRNM and KDIGO sessions also in this webinar, in this Congress. So with this, I would like to hand over to Professor Christoph Wanner to chair this inaugural joint education webinar of the two organizations. Thank you, Christoph.
Thank you, Angela. Very pleased to moderate this today because I remember that I became member of ISRNM in 1985 already when I had a talk in Williamsburg Congress. And I'm with KDIGO from the first day of the foundation of the Kidney Disease Improving Global Outcome Initiative and Guideline body. So I'm happy to have here a panel of speakers, and on the next slide you see Katy Wilkens. She is workgroup member of the KDIGO guideline on diabetes. She is from Seattle, and you may see then later on her first slide her prominent role over the years. She will give a talk and then we discuss it with Denise Mafra, professor of clinical nutrition, and currently at the University of Glasgow, but professor in Brazil. Tami Sadusky, she is a patient advocate and also member of the KDIGO guideline diabetes management in type 2 diabetes work group, and she was the patient advocate in this group. And you already heard Angela Wang, the president of ISRNM, and a nutritional specialist and well placed here to discuss today lifestyle in the KDIGO guidelines. And finally, Kelly Lambert, an academic program director on nutrition and dietetics at the University of Wollongong in Australia. So nice, and thank you for having you here. And I will give you a short introduction also on this new update in KDIGO guideline. And this update came out actually a couple of days ago. And you may be interested what the, excuse me, this is the wrong, I have to stop here. I pulled up the wrong presentation, and this gives me a minute to pull up the other one. Something always happens, and this is the ISRNM introduction on diabetes management in CKD. And with my first slide, you see my transparency declaration with companies working in the field of anti-diabetic medication and doing large clinical trials. Here you see the March 2020 to update in KDIGO guideline a comprehensive care to reduce risk of kidney disease progression and cardiovascular disease. And you see the bottom of this famous pyramid with diet, exercise, smoking, and weight control, all going in the basket of lifestyle. And we may talk about this because this is the basement of all other treatments we have today. So this is the treatment in respect to first-line drug therapy. We have currently 4 major interventions, organ protective treatments for kidney disease progression and cardiovascular disease. And
Can I
then
pause you for one second, Dr. Wanner? People aren't able to see your slides.
Yeah. You need to share. You need to share.
You didn't see the slides?
No. I think it was correct the first time that you shared.
And then they vanished, apparently.
Yeah.
Here we go.
Yeah.
So again, my introductory slide, apologize, the next transparency declaration, then the basement of the pyramid with the lifestyle intervention I was talking on. And this pyramid was then developed by KDIGO into the first line drug therapy with these 4 organ protective intervention and some goal-directed therapies. And I will talk about this. And only as an introduction that we have drug treatments available which are prominent and which going across the world to our patients, but all is based on the basement of lifestyle. And this is today's intention to talk about. The guidelines, for example, for RAS blockade are as follows. We recommend that treatment with an ACE inhibitor or an ARB be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications be titrated to the highest approved dose that is tolerated. And this is a prominent high grade grading of a guideline. I think this intervention and this guideline will be discussed in an upcoming webinar of KDIGO and ISRNM announced around in April. This is the 2nd webinar on blood pressure management. So please watch out to hear more about this. The next guideline is about metformin. In diabetes management, we recommend treating patients with type 2 diabetes, CKD, and an eGFR above 30 with metformin, also strong. The evidence is not so strong, but across the globe, we are talking, metformin is available in most countries and to our patient. Therefore, we keep it still in the guidelines. Here, our strongest guidelines, 1A, we recommend that most patients should get this treatment. Treatments are with an SGLT2 inhibitor, and new is with an eGFR above 20 ml per minute. Previously, it was 30, now it is 20. And don't stop SGLT2 inhibitor when patients go towards dialysis and fall below 20. So a very strong guideline. And finally, we have a new chapter in our updated KDIGO management. We suggest a non-steroidal mineralocorticoid receptor antagonism with proven kidney or cardiovascular benefit for patients with type 2 diabetes and an eGFR above 25, normal serum potassium, albuminuria despite maximum tolerated dose of RASI. Also a very strong A. A means that we have a randomized controlled trials. Actually, we have 2, one for cardiovascular outcome, one for kidney outcomes. And this comes into the public review in the moment, which is out there since a couple of days, and you can freely download these and review the guidelines. Therefore, I'm coming to my last slide, this holistic approach. Again, we talk about lifestyle today on the top, and then is coming the first line drug therapy. And the interventions have impact on the kidney, on the heart, and maybe on blood glucose control or weight control. And this is all indicated in these insets or blood pressure. And you have here an algorithm where you can use these modern organoprotective therapy, which are apparently in some instances more effective when you also combine them with lifestyle treatment. And here I will stop, and with my introduction, thank you, and I hand over now to Katy Wilkens, and I think we will get the presentation now from Brandon, please. And I also want to remind you, bring your questions into the chat now.
I am so glad to be here today. You know, we all have the opportunity to decrease a lot of misery and save lives around the world. We are what we eat, and I think it's a really good reminder of how important nutrition is. Okay, so I clicked on the screen. There we go. Sorry. Anyway, I recently retired from a job I have loved for about 42 years at the Northwest Kidney Centers. I had a great experience there with the amazing renal dietitians I supervised, as well as over 2,000 patients with various stages of kidney disease. I was really thrilled to be asked to be on the KDIGO work group, because I think as a dietitian, I just feel like prevention, you know, we're spending an awful lot of money dialyzing people around the world when we could be spending a small amount of money and making them healthier. And I think partially the reason I was invited to participate on that group is I was the editor of the American Dietetic Association suggested guidelines for nutritional care of renal patients. There's about 3 editions in the 1990s. That was a great learning experience for me, and I have no financial interest to disclose at all. Okay, I want to introduce you to KDIGO for those of you who might not be familiar with it. It can get a little bit confusing. There's both KDOKI, which are USA guidelines, as well as KDIGO, which are international guidelines. And what I love about KDIGO is, you know, it considers the whole world. Many countries have no such thing as a registered dietitian. In some areas, you know, in some countries, rural areas are greatly underserved medically. Some countries may have no healthcare insurance. Other systems may have a national healthcare system. There's the whole affordability issue of diabetes medications, availability and cost in some countries. You know, some countries have much higher rates of diabetes than others. And of course, unfortunately, we have the sad specter of starvation and food insecurity around the world, limited access to the right kinds of food. And then finally, a conundrum that I have experienced, which is that people are not rats. And it is very hard to look at random control trials for nutrition needs. We use mostly epidemiological information, which is great on a big, broad spectrum, but it's not quite the same as, I've always wondered how you would give someone a plant-based diet and blind the educator and the consumer. So anyway, that's just a part of that. And then I do want to remind people that the guidelines are available in multiple languages. These are all volunteers who translate this information. So if you're interested in translating the guidelines into your primary language, please contact KDIGO. They're always looking for help. I want to introduce Tammy Sadusky. Tammy is on the KDIGO guidelines group with me, and I have so enjoyed her presence there. I asked her to send me a picture, and she said, do you want a professional picture or a picture where I'm having fun? And I said, I think we need a picture where you're having fun, because that's the whole reason we're doing this, is so that everybody can have fun and a much more interesting life. I will point out today there are about 5 chapters in the KDIGO CKD and diabetes guidelines. I am only going to talk about chapter 3, the lifestyle intervention. So if you want more information on all the other sections, you'll have to go refer to those. And then I do want to kind of clarify, we have both practice points and recommendations. The recommendations are categorized based on the strength of the scientific evidence. Practice points are not. And again, we come to that bugaboo of people are not rats, and it's hard to use individual RCTs in nutrition therapy. I will just point out quickly, there's the top 10 for patients and for clinicians at the KDIGO website. I encourage you all to look at these. These are a nice summary of the guidelines. Again, not to belabor the point, but I think dietitians really can make a difference. There's a bunch of studies here. I'm not going to review them, but there are things you might want to look at when you're thinking about how you're going to educate these patients so they can make major changes in their lives. I think the real problem with the Ckd diabetes diet is that there's only 4 things in the world that have calories: carbs, fat, protein, and alcohol. And then we tell people with diabetes to limit them all. And, you know, on top of that, there are issues of income. Some patients have no cooking abilities, cultural food availability, comorbidities, you know, and there are an awful lot of patients who would very willingly trade decreasing or moderating their intake to reduce side effects. They just need to know how to do that. And in my work with CKD patients, the most common phrase that I heard when teaching classes, which I did for over 40 years, was, "Why didn't someone tell me about this sooner? I could have made these changes a long time ago." So that's what we're going to work on today. So here's our first practice point. Notice it's a practice point, not a recommendation. Patients with diabetes and CKD should eat a diet high in fruits, vegetables, whole grains, fibers, plant-based proteins, and avoid things that we know are unhealthy for everyone: processed meats, refined carbohydrates, and sweetened beverages. You know, it sounds so easy. This is the $1 million diet. If we could just get people to do this, we could decrease so much misery around the world. It's not glitzy or glamorous. You know, it's not the grapefruit diet or the keto diet or, you know, any of these other diets, but it really is a basic pattern for healthy eating. I do want to just stop and say all the patients in my presentation have given their permission for their photos to be used in education programs. This is Mong. She started dialysis in 1982. I've been her dietitian for 40 years. Okay. So again, this idea of a normal healthy diet, increasing the intake of fruits and vegetables is probably the most important thing everyone on the planet can do. We did try and suggest adding vegetables to all 2 to 3 meals that people eat a day, and trying to represent all the different ways that people can eat here. If you have some other way of eating afterwards, send it to my email so I can add it. We'll add it to our little pictures here. Okay, here's our first recommendation: protein. We suggest maintaining a protein intake of 0.8 grams per day for those with diabetes and CKD who are not treated by dialysis. What's the really most important word here is maintaining. We struggled over this recommendation for so long because, you know, in some countries protein intake is high, in others it's low. What we settled on was the World Health Organization recommendations. I mean, if anyone knows what normal healthy people should eat, it's probably the WHO. And 0.8 is the recommendation for all normal healthy people above age 12 on the planet. So this seems a reasonable recommendation to make, and particularly in light of some countries where protein intake is historically low. This might actually be an increase in protein intake for some people. In other countries where grains provide the majority of the protein, decreasing protein intake may actually dramatically decrease carbohydrate intake and hence calorie intake. And in high protein consuming countries, protein may need to be decreased. So I like the word targeted protein, targeted to the patient's needs at 0.8 and not either high or low protein. Why is protein so important? Well, in addition to the complexities of protein metabolism in normal healthy people, for people on dialysis, for people with CKD, when you lose kidney function, you lose the ability to break down insulin, and the half-life of insulin increases. So patients, so many patients would come in to see me and say, oh, I used to have such a great regime, and now I have low blood sugar episodes at really weird times. I take my insulin when I've always taken it, and all of a sudden I can't seem to manage my hypoglycemia. The other thing that's going on with these folks is that when the kidney function decreases, the kidney also loses the ability to perform gluconeogenesis. That's about 20% of the glucose that your body produces. And then some patients will have almost normal blood sugars, even though they're not really following a diet because of this extension of their insulin. A1C, another complication to really be aware of, is not a great indicator in people with chronic kidney disease as they become more and more anemic. The half-life of their red blood cells shortens, and it's just not as accurate a number, and we don't really have a good measure in these people. So I'm just going to put a caveat in here. For dialysis patients, we left a protein recommendation of 1 to 1.2, but we're not really going to talk about them anymore, just to differentiate between those patients on dialysis and those patients who are not. The protein recommendation, how much is 0.8? This is a question I get from so many dietitians. What about overweight patients? What weight am I supposed to use? And our recommendation is to either use an ideal weight for the patient's height, or what the World Health Organization recommends is to use the median weight for your country. I like to say for a 70-kilo person, this would be about 56 grams of protein. And a reminder, because I've seen this mistake made by non-nutrition professionals, don't confuse grams of protein for weight in grams. 100 grams of meat only contains about 24 grams of protein. There's water and all kinds of other things in there. All right. Where protein comes from, again, I'm not going to really go over this with this audience, but what I would like to say is this additional plant proteins. If anybody has some kind of fun plant proteins they'd like me to add to this list, I'm kind of collecting them. And so again, you can send that to me afterwards. Our next recommendation is sodium. Again, looking at RCTs, the standard recommendation for sodium, there's a standard of evidence is actually pretty high for decreasing blood pressure. That I don't think most people would argue with. The World Health suggestion is under 2 grams of sodium per day. If you're more comfortable using grams of sodium chloride, it's about 5 grams. But the evidence gets weaker as we move down to progression of kidney disease. I think part of the reason for that is, there's a huge number of these patients who die from cardiac death before they get to their progressive renal failure. And so I think it just completely messes up trying to look at the evidence. So anyway, the standard of evidence is not great. But we do know over 2.5 million lives a year epidemiologically are lost to salt. I mean, if you think about it, that's about how many lives we've lost to COVID in the last year. So the World Health Organization recommendation for everyone on the planet over age 12 is 2 grams of sodium, and that seems a reasonable amount to recommend to diabetic patients with chronic kidney disease. There's no clear benefit for targets lower than 1,500. So again, not making the patient miserable and no real notice in difference of doing that. I do want to remind everybody that in a week or so, we have Salt Awareness Week. It's international awareness, and their topic this year is Shake the Habit. I put their website, and they have free posters and handouts, so great education material available from them. So when we go to the sodium recommendation, I think it's always important to talk about reasons why we shouldn't implement this standard. Low sodium intake may decrease the palatability of food to some people. And it's certainly foods, if we remove sodium commercially from foods, it increases perishability or decreases the shelf life of foods. And in countries where there's limited availability of food, this might be a serious consideration, right? If sodium intake is high, patients may have to decrease some of their favorite foods. Here's one of my patients, Kathy, with her breakfast snack, right? The sodium intake may require the family to change their intake if the patient has to lower their intake, or it may isolate the patient. I have some families where they say, oh, well, he just doesn't eat with us anymore because our food's too salty. So such a sad thing to think about, right? But the pros, the positive things about this, patients can avoid or decrease their use of costly medications. And I think this is something that we kind of brush aside, but it can have a big financial impact on a patient and their family. They certainly can lower their blood pressure. There's no question about that. And, the package insert on most antihypertensive medications says to be taken in conjunction with a low sodium diet. So that diet will help those blood pressure medications work better. Patients might need a reduced dose or a less complex regimen, and they might be more compliant as a result. And the other thing I find really rewarding is that often what we can do is substitute culturally lower sodium alternatives for kind of the Western prepared packaged foods that patients may be eating. Certainly we've seen with COVID, a decrease in eating out, which has had good, healthy ramifications for a lot of people. Although I do find myself now having to ask people, well, okay, if you don't eat out anymore, do you get takeaway? And then again, adjusting the family's intake. If there's a patient with CKD in that family, chances are the other family members are at higher risk. And so it actually can be a benefit and help to everyone in the family. And it is possible to decrease your taste threshold for sodium. It only takes about 4 to 6 weeks. I always tell people that taste for salt is learned. It's not inherent. It's not heredity. And so patients can change their behavior. And usually I know they're doing this. They come back and tell me, oh, I went out to a restaurant with my wife and the food was so salty, I couldn't eat it anymore. Okay, I always like to tell people what to do and what not to do. This is guidelines in the points in the guidelines to help people reduce their sodium. Shared decision making. Perhaps the most important thing I'm going to talk about today is to get the patient involved. And this is one of my patients, Rochelle, who has a PhD in anthropology. She's Samoan. And we had a great discussion one day about, she said, Katy, what if the cure for diabetes was speaking Samoan? What would we do to make sure that every single diabetic patient in the world could speak Samoan? We would educate them. We would have them watch Samoan soap operas. We would give them a Samoan speaker to call them regularly and check in with their progress, right? We would do all kinds of skill development for this person to be able to speak a foreign language. But when it comes to following the diet, what do? We say, oh, don't eat salt, don't eat sugar, off you go. And then we're surprised when they can't be successful because we haven't educated them, right? And it is a life skill. It takes a long time. It's as complicated as learning a new language. Again, this shared decision-making, the patient often comes up with solutions that the provider never would have thought of. I've had this happen 1,000 times to me. And I think important to recognize that behavior change takes 2 to 8 months or longer, and that patients are going to make mistakes, and they're going to fall back on their old habits, and then they're going to have to readjust. But the most important part of this is it's patient-centered, and the patient is the one figuring it out. Oops, sorry. Okay, the nutrition education, the practice of nutrition, I think is super important. Obviously, I'm passionate about it. But the reality is there aren't dietitians everywhere in the world, and we have to have a way to educate patients and to have the time to spend with patients so that they can really learn this complicated language of nutrition that we're talking about. And sometimes there aren't going to be those credentialed nutrition professionals, and they may be unavailable, they may be unaffordable, but I think that opportunities exist in public health systems for peer counselors or community health workers who have been trained maybe by a higher level skilled person to give the patient these options, right? Again, changing intake takes a lot of time. It's possible that the physician doesn't have the time and frankly might not have the expertise in modification of the patient's diet. It takes, kind of complex reporting by the patient on what they've eaten, what they've been changing. The person analyzing their intake has to have a good database to look at and see what their intake is. And then patients have to have alternatives suggested to them and come up with their own. So this is a time-consuming process. It doesn't happen in a 1-hour visit. It takes months, right? And it takes repeated contact, learning errors, all the kinds of things you would do again if you were learning to speak a new language. Peer coaches, community health workers, all of these people can help. And a reminder that patients who have low health literacy are probably going to take even more time. Although one of my patients who did the best job at following her diet was blind and took the bus every day to the grocery store. And one of my pharmacy patients couldn't follow his diet for the life of him. So healthcare providers should consider cultural differences, intolerances, and other comorbidities when they're recommending a diet. That goes without saying. It's hard to give up foods you like, but if you have options for the patient, they can usually find improved quality of life. The family obviously plays a role in important decisions and should be involved. Often they are either substituting the patient's intake or providing income to the patient to afford medications, right? These are all considerations that are affecting a whole group of people, not just the individual patient. Technology certainly can help. I do recommend patients use their mobile devices to get nutrient databases and et cetera. And then lastly, we talk about exercise. What if there was a pill that you could take 3 times a week that really helped your cardiovascular disease, your diabetes, and your chronic kidney disease? And what if that pill were exercise, right? So we recommend that patients should be advised to avoid sedentary behavior. Walking is a great exercise that most people can do, and the physician should be involved in the evaluation of the patient's activity. So again, my take-home points: a diet high in vegetables, fruits, and whole grains. This is for everyone on the planet. Maintain a protein intake of 0.8 grams per kilo, again, for everyone on the planet. Sodium intake of less than 2,000 milligrams. This is for you, me, and our patients. Shared decision-making is essential. Use nutrition professionals when possible and have a plan for when it's not. And consider cultural, economic, and skill differences. Physical activity is key. There you go. So this is my email. If you want to send me those information on your food sources or have questions or later need follow-up, feel free to contact me. I'd love to chat about food. Thank you.
Thank you, Katy. Very well received. We have half an hour for discussion, actually very comfortable. And I received already a question in the chat box and about ketogenic diets and about protein. So please, the audience, think about more questions and put them in the chat and we can discuss them. But with my first question, I would give the patient the preference, and Tommy is with us, and I would ask her, the first question is that we doctors, Tammy, we use a language including sodium chloride, then we use salt, and then we use different measures, 2 grams, 6.5 grams. Is this a little bit confusing for patients? What is your opinion about salt and sodium chloride? You are still on mute.
All right, thank you. Yes, that's an excellent question. I think one of the most important things in really helping a patient is to speak a language that both the patient and the healthcare providers, doctors, nurses, dietitians really will understand. And so when you're when a healthcare provider is talking to a patient, it's good to ask, you know, if I'm talking about these terms that are unfamiliar, to really come to a consensus on what something means. So most patients will easily relate to salt or sodium, but when you go beyond that, they may have difficulty understanding what you mean. So for a patient, education, I think, you know, Katy pointed this out, is to really speak the same language and educate the patient on what you're asking them to do or telling them to do, but for the patient also to ask questions if they don't understand. So really a teamwork, but as far as salt and sodium, just coming to a consensus on what is the best term to use for that patient. One patient you'll find is much more or highly educated in the nutritional aspect, and others may not be so much. So for the healthcare provider to get a baseline of where that patient is and then be able to discuss those type of things, sodium and protein and things like that with them.
Thank you. So if others from the panel have emotions, we have this hand raising function, and then we can lively discuss. Very nice. I see that Kelly was unmuting. Did you want? Yes, there's a hand, please.
Yeah, thank you, Chris. I was going to say, I think that that's the most challenging thing I find as a dietitian, is that patients have been advised to think about nutrients, but we eat food. So we talk potassium and protein and phosphate, when in real life people eat food. And I think that's the major source of confusion that we need to move away from, and to talk more about food. And even terms like balanced diet is not necessarily intuitive. I think that's something that also needs to be explained and have a common understanding of what we mean by that, because it does mean different things to different people.
Thank you. Good. And then we have from this famous nutrition school in Brazil, we have a student, a PhD student here, asking, why don't we use 0.6 gram of protein if we can manage carbs and lipids? Angela, you come from the time where we did excessive 0.6, also in the Eastern Germany, we use this. Why did we abandon 0.6, or can we still apply this? Angela, maybe.
Thank you, Christoph. So I think from my understanding at the moment, the 0.6 gram per kilogram per day, actually it was not supported in the diabetic group of CKD. We do have studies in non-diabetic CKD to show that adopting a very low protein diet with a keto as a supplementation may actually ameliorate the CKD progression and reduce kidney death. But I think the similar data in the diabetic population are actually lacking. So clearly, this is a gap area, a knowledge gap, where we need to, expand the study in this particular group of patients. And in particular, I think for the diabetic, lowering the protein intake might have a concern, because one also need to restrict their energy intake. So you really need to actually balance the protein and the energy to make sure patient doesn't go into protein energy wasting.
So this is very controversial, maybe. Katy, do you have a hand up? Yes, please.
I do. Angela is exactly right. And there is just, they did these Cochrane reviews for us, thousands and thousands of articles looked at. The data for diabetes is just not there. And if you think about it, diabetics are often excluded from studies, right? Okay, we're going to study XYZ. Well, we're not going to have people with diabetes in that study because their metabolism is so different, so we'll exclude them. They're just not the data. And again, going back to this, people are not rats. it's just impossible to find any validity for that. And again, the complexity of managing a restricted carbohydrate, moderated fat diet, and then limiting protein, we just don't want patients to have hypoglycemic attacks, because in fact, protein helps carry them through often those low glycemic episodes. So we're trying not to do any harm to these patients while we navigate the fact there is not really good science behind the low protein diet in the diabetic.
Excuse me, I have a paper in the New England Journal from, I think, the year before 1990 in mind, but maybe these type of trials in the early days were not sufficient to bring us a high grade of grading today. Yeah, so you may be right. Yeah.
I mean, the grading on the nutrition articles, it made me so sad. They were just, the grading was very poor.
And then I have a question maybe for Denise from Giacomo Garibotto. Can you update us on ketogenic diets, which are often suggested to patients with type 2 diabetes?
Yeah, this is a very good question because it's linked with protein diet. So if you reduce the carbohydrate, so a low carbohydrate diet, it's very, very common in, for example, in Brazil, I know in the other country, but in Brazil, dietitians or even nephrologists love to prescribe low carb diet. And this is, for me, that's my opinion, it's dangerous because you need to increase the protein intake and the lipid intake if you reduce carbohydrate. So more than 0.8, this is a huge discussion about the 0.6 and 0.8, but even more than 0.8, it's a high protein diet, in my opinion. And so this is not good for our patients. So I don't agree with a low carb diet promoting a keto or ketogenic diet. So we need to have a balance between protein, carbohydrate, and lipids, and the kind of lipids. So it's they like this kind of diet because it reduces weight. Of course, we change all metabolism, but we need to know the consequence of this. So what kind of lipids they are eating, or how much protein they are eating, you know. So well, I don't agree, but it's my opinion.
These non-saturated fatty acids, or do they contribute to the cholesterol level or not so much?
Yeah, so I think, well, in Brazil, they can eat all the protein and the lipids, you know, so they don't pay attention to the quality of lipids. So this is important.
Very good. And then we have a question maybe to Kelly. In your parts of the world, you sometimes find underweight patients. Should we use actual body weight or ideal body weight to estimate protein intake?
Yeah, that's a good question, and you'll probably get a million answers depending on who you ask. In my practice, if I had somebody who was underweight, I would use actual body weight. But if they were overweight, I would use an adjusted body weight, but never actual if they're overweight or obese. You're just going to give them far too much protein than they need for the amount of metabolically active tissue that they have. But I'd be interested to hear what the other dietitians on the panel do in their parts of the world.
Hong Kong has small body weights sometimes, or I think it's an often asked question in Japan. Especially when I want to treat these patients with an SGLT2 inhibitor, where they lose a lot of calories through the urine. Yeah. So, okay, so everybody's happy with your question. Then we have a very, very long comment, which is difficult to read for me, from Dr. Liu, the president of the International Federation of Kidney Federation in the World Kidney Alliance, as a moderator when I concentrate on question and answers, but maybe people want to read it also alongside and can have a feeling. Then I have from Luis, diet fits nicely queries the proposed benefit of low carbohydrate. I'm not familiar with this term. Can somebody help me and answer this question? Who wants to take it? Denise? Is diet fits? Maybe we need more explanation. Denise,
I think it's the same before. So discussing about carbohydrate, low carb diet, I think. Yes, so.
Okay, a comment more or less. Then Kelly.
Yeah, I was just going to add to the discussion from Denise about the low carbohydrate keto diets. I think the other thing that we kind of forget is that when you reduce carbohydrate, you're going to reduce fruit and vegetable and breads and cereal consumption. And, you know, that fiber intake is really important for the gut, for people with kidney disease. And I think, you know, we're actually putting people into more harm's way by, you know, changing the profile of the gut. So I think low carb diets for people with diabetes and kidney disease aren't the way to go in the long term. Perhaps short term, but not in the long term. I don't think that's a good place to be.
Yeah, totally agree.
Right, and I would agree, and it's from the patient's perspective, you know, they're hearing low carb diet, so they're eliminating the whole grains, and you know, they're not eating oatmeal in the morning like they used to. You know, now they're eating bacon because, well, that's a fat and that's okay. So there's such a misconception from individuals about what that really means. I was talking to a few people on an advisory council, and they were very firm about not eating anything, any potatoes, sweet potatoes, or all of these things that are really good for people with diabetes to eat, but they saw it as a carbohydrate food, so it was off the table, and they're really eating only protein, which is of course not good. And so you can almost see the problems that are going to be in the future for them if they don't kind of get back on track. But there's just a misunderstanding out there what a healthy low carb diet means.
And I guess I just wanted to add that the Cochrane Review Group looked at ketogenic diets. We looked at the Mediterranean diet. We looked at high protein diets. We looked at low protein diets. We looked at everything, right? And there was no indication for any of them. Even the ones that I wanted there to be an indication for, there wasn't. So I think the science is just not behind that.
I see very good comments also in the chat, which are complementing what we are saying. So I don't read them, but I leave them. And then I have still three legacy hands are up, maybe from you. Good. Okay. So, no, Denise, you had a question, comment. Yeah, please. No? Okay. Then I would like to stress one topic, which is very important. Since KDIGO has brought the new non-steroidal mineralocorticoid receptor antagonism in the guideline as an important organ protective treatment, and many people, doctors, will use it. These non-steroidals, they have minimal risk of hyperkalemia, but the risk is there. And maybe we dietitian and nutritional focused people have also to look in the future and give advice on potassium. So on the one hand, we give our advice to use vegetables, diet high in vegetables and fruits, but maybe to earlier stages of CKD and not to late stages. On the other hand, we need now to bring this potassium issue in. We have, on the other hand, binders for potassium, which maybe can be used, but also limited their prescription when we combine it with diet. So who wants to take this question or a comment to my question for the future of the advice of vegetables and fruits in respect to potassium? And I see a hand from Kelly, please.
Thank you. I think you can still have fruits and vegetables at all stages of kidney disease, regardless of whether you're on those medications or not, and to avoid them would be foolish. I think we need to focus more on the large sizes of the portions of meat or the discretionary junk foods that are contributing sources of potassium. And from my perspective in my country, even more concerning for me is the creep of potassium chloride into foods as a substitute for sodium, but we don't have them potassium on food labels in Australia. So we have potassium chloride coming into staple foods, but without any labeling to allow us to educate patients. So I'd keep the fruit and veg in and be a little bit more wary about some of the other sources of potassium personally.
Salt substitute, very good. Yeah, I think Denise, you had a hand up or not? No, actually not.
No, there are more questions about low carb.
Can you address them, please?
This is question and answer. It's about the possible mechanism for low carb diet not working in this patient. So low carb is always like that. It's people are crazy when discuss low carb diet. I think we discussed before. So we need to pay attention the balance of carbohydrate, lipid, and protein for our patients. So what kind of lipid and carbohydrate and protein we are prescribing. I think well, it's a huge discussion.
Okay, and the last question about leaching and double boiling, I think is what we use since ever in more dialysis or end stage when we have potassium issues. Is this correct, or it's not fresh fruit or vegetable anymore? Katy, you want to add something?
Yeah, I was just going to say you can actually soak things like melons and squash and things, but you know it's such a burden on the patient to do that extra work and I have very few patients that are actually willing to do it. And I think it really only makes a difference in foods that are quite high in potassium. So, you know, I don't think it's sure, it might be a tool in occasionally in someone's toolbox, but I don't think it's routinely recommended. And I would normally just suggest the patient make a fruit or vegetable choice that's a little bit lower and not have to deal with processing it. You can dialyze foods, you can remove their potassium, but it takes a lot of work. And the diet already takes a lot of work. So we're trying to make things easier for patients, not harder.
Kelly, and something?
Yeah, sure. I was about to say that there is concern about potassium in fruits and vegetables, but it's not as bioavailable as we previously thought. So, you know, you might look at it on a food composition table and a potato might look high, but in actual fact, the bioavailability is probably half of what it looks like on a composition table. So I don't think it's as much of a concern as we used to think it was. And the same with nuts as well. Whole nuts, fantastic food, look high in potassium on a food composition table, but because of the structure of the potassium in the cell wall, it's actually not as bioavailable. So those sorts of things are really healthy for patients to eat and shouldn't be avoided.
Okay, then I have a question to Tami about professional nutritional consulting. How many sessions do you expect are useful? How many sessions a doctor should prescribe to send the patients to professional nutritional consulting? What do you think?
Well, I think as we talked about before, it's every patient is an individual and everybody's a little different, and their knowledge of nutrition is so varied. It also depends a lot on where you're from. You know, the KDIGO guidelines are worldwide, and what's available for patients in the United States or Australia or India may be quite different. So the resources that are available will kind of play into that. But I think the healthcare provider, before prescribing anything, is really, what is available and the patient situation and their base knowledge. So saying, 3 sessions will do it, or this patient may need 5 sessions is really hard without really looking at that patient. And there's so much information that what I like to advise other patients is that really do as much research and become as knowledgeable as you can on your own. There's a world of information now online or with peer groups or through public assistance areas that they can gain that knowledge too. Sometimes it is much easier for a patient to talk to their peers and learn from their peers than it is from a doctor or a nurse. It's just when you say, what were you told and how do you handle this? And sometimes the progress you can make in peer groups and support groups is so valuable. So I think, setting the number of sessions is quite difficult without really talking to the patient and finding out what they think they need. The patient voice in making healthcare decisions is so very important.
This brings the word personalized into the game. Very good, yes. And then Professor Wang had his hand up, her hand up since long. So Angela, you are on mute.
I actually have one question for you, and probably one question also for the panel. And this question is that you mentioned just now about the update of the KDIGO guidelines on the use of MRAs. And, managing potassium is always difficult in some advanced CKD patients. And we know that there are also new phosphate binders available on the market. So I wonder if you may be able to advise the audience as well as the group as to, how you would balance the use of the novel potassium binders as well as using dietary measures. Especially Kelly mentioned about that we should not restrict dietary potassium intake.
You want to have my opinion now, what I'm doing. Actually, I move very much to the personalized approach. I talk to my patients. I know how much pills they want, the burden of a new medication. Some have no problems to take in a short period of time the new binders. Others cannot tolerate it over longer periods. So it's many respond to diet. So I think I have a broad mix, and the patient sitting in front of me, what are his means, what does he want? Yeah. So I have 2 questions maybe for Denise. They come together. Maybe what about metformin and what about vitamin D monitoring? Could you focus on these?
No, yeah, it's not my question. It's question and answer here. So one of them is about metformin reduce vitamin B12. So the question is if do you use to monitor vitamin B12 in your patients? I think that's it.
Okay.
Christopher or Angela?
No. Very good. Short answers, short question, short answers. Very good. Yeah.
One question I would like to, Christoph, one question maybe I would like to raise to the groups is about education. Like I think the IFKF president has mentioned here about the health literacy. So I think the KDIGO guideline mentioned about the sodium, the recommendation in the diabetic PD patients or also for blood pressure control. And we know that in many parts of the world or in emerging settings, perhaps there is also the issue of food insecurity. So how I would like to check, have the panel to give all of your views, or also the moderator, You know, how do you think we should improve the salt literacy or the health literacy in kidney patients in order to, you know, improve the dietary intervention in this group of patients?
So Dr. Lambert Kelly, please.
I'll start. I think for us, we have to start with the way we deliver messages. So for me, Teach Back is the number one way that I have changed my practice. And so that's a way of checking that I've delivered the message to the patient and that they understand. It's not the patient's fault they don't understand. It's my fault for not delivering the message appropriately. So in order for patients to action the information, they need to understand it, and it comes back to me as the health professional. I think for me that's where it starts. It has to start.
Are you happy, Angela? But Katy has also a comment, please.
Well, I was just going to say, you know, we have a great RCT in Great Britain's starting their salt reduction, then stopping it, then starting it again. I think it was 100,000 lives saved per year when food manufacturers in England decreased their sodium from mandatory requirements. And then when those were lifted, those deaths went right back up. I mean, it's pretty insidious how much salt is it. 90%, something between 80 and 90% of the salt that you eat, someone else has added to your food who doesn't know you and doesn't care about your health. 80 to 90% of the salt. So my patients will say, oh, I've stopped salting my food. And I'm like, well, that's great. Now let's focus on the rest of the salt that someone else is adding to your food who is not invested in your healthcare.
Okay, so we have still a couple of questions, but we are also coming to the hour. I acknowledge the question of Dr. Fahn about the phosphate and the protein balance in hemodialysis patients, but I gave an entire lecture about this recently. Maybe very, very good question, but complex. So if the panel has no urgent question anymore, we are past the hours. We got now applause. Love this discussion. Thank you all. We had 90 participants, what I'm seeing here. This is a great success. Thank you all for your lively participation. No more urgent things here. So again, thank you. And we are looking forward to the next ISRNM and KDIGO session on blood pressure control, and you get the alert in due times from our president, Angela Wang. Thank you very much.
Thank you. You can register at both organization websites. And also, just add on one comment, you know, the video, this session is being videoed, and so the video will be available on both the KDIGO and the ISRNM website. Thank you.
Thank you. Bye.
Bye.
Bye-bye.